Dr. Josh Woolley is an associate professor in residence in the Department of Psychiatry and Behavioral Sciences at UCSF, as well as a staff psychiatrist in mental health at the San Francisco Veterans Affairs Medical Center. He's board certified in psychiatry by the American Board of Psychiatry and Neurology. He's the director of the Translational Psychedelic Research Program at UCSF, which brings together scientists and care providers across disciplines to understand the efficacy and mechanisms of psilocybin, LSD, ketamine, MDMA, and related compounds as treatments for neuropsychiatric disorders. Today, he'll be talking to us about psilocybin therapy, current challenges, future prospects. Thank you so much. Passing the baton to you.
Yeah, so tonight I'm talking about psychedelics and psilocybin in particular. First, I have some disclosures. I've been a site PI on a couple of sponsored studies. I've also a paid consultant for a couple companies. Unfortunately for me, I don't have any equity in any psychedelic company, and I won't be talking about any research that's directly supported by any of these companies tonight. So I'm a psychiatrist, and I can say that we need new treatments. There isn't a single disorder in psychiatry that we've cured, which is actually kind of surprising given how other branches of medicine have done. Many diseases have been basically cured. And in psychiatry, not only have we not cured any disorders, we still have disorders that have no effective pharmacological treatments. For example, eating disorders, personality disorders. And then for the disorders that we do have effective treatments, they're insufficiently effective. Just to take one example, depression. This is just one of the illnesses that we talk about in psychiatry, but it's a big one. It affects over 264 million people across the world, and it's the leading cause of disability worldwide. It's a leading cause. It's in the top 10, according to the WHO. It's the most associated with suicide, and 800,000 deaths are due to suicide each year. And not only that, depression can affect many different aspects of people's lives, even when people don't commit suicide. Unfortunately, the treatments that we have for depression, 1/3 of people will not respond, roughly. And the treatments that we do have work through similar mechanisms. We've been, manipulating serotonin in various ways for a long time. And the treatments also have side effects, sexual side effects, for example, with SSRIs. And most of big pharma has gotten out of making drugs for the psychiatric illnesses. So we have not been getting lots of new drugs like other branches of medicine. This is just one example, but this is true for many of our disorders. So we are in desperate need of new effective treatments. Some of you may remember this guy. This is a photo of Nixon signing the Controlled Substances Act in 1970. Now, before 1970, psychedelics were being studied across America as treatments in various ways. They were also being used for other things. Some of you may remember that part. But this law basically started the war on drugs and ended abruptly research on psychedelics. And there was basically a huge hiatus, a gap, a dark period where no progress was made with psychedelics. But things have changed. Over the last maybe 15 years, there has been a loosening, an ability to study these things again. We at UCSF and other places like Hopkins and Imperial in the UK, NYU, many other places as well, have been able to do clinical studies with these compounds again. And there's been a resurgence of interest and a lot of excitement. So let me just tell you about psilocybin. So that's the one that has been studied the most. So psilocybin is the active ingredient in hallucinogenic mushrooms. You can see the mushroom down here on the right. It's not just one kind of mushroom. It turns out there's about 180 different related species of mushroom that contain psilocybin. we know that psilocybin gets metabolized to psilocin. So it gets broken down to a compound called psilocin, and psilocin is the active ingredient, the active metabolite, excuse me. And we know that while psilocin has a complex pharmacology, it binds to many different receptors, we know that through this particular kind of serotonin receptor, the 5-HT2A receptor, that's what causes the psychedelic experience. And we know that because if you block that receptor with a drug that is an antagonist at that subtype of receptor, you can block the psychedelic effects. When you take psilocybin at a usual dose, you have effects that last about 6 hours. This is convenient because it means that we can use it and have the whole experience be within a workday. Some other psychedelics that you may have heard of, like LSD, have a longer half-life, so that would be a much longer period. It's a sympathomimetic, which means that when you take it, people's heart rate and blood pressure go up. And this is the part that, it kind of, we make it seem so sterile with our scientific language. It has potent effects on perception, mood, cognition, and behavior. That's what we mean by psychedelic effects, or the trip, if you will. I'll get more into that in a second. But some people describe it like dreaming while awake. And this is the compound that has been studied the most in this modern era of psychedelics. And there are a growing number of trials suggesting that it can be helpful for several different disorders. I'm only going to be talking about some tonight. I just want to take a moment to talk about this art here in the top right-hand corner here. This is from a cave. It's a cave painting in Algeria, I believe, called the Bee-Headed Shaman. And you can see that along this figure's skin, what looks like mushrooms, and then both fists are full of mushrooms. And then the head is replaced with a bee, hence the Bee-Headed Shaman. And those mushrooms that are depicted look a lot like the mushroom that we're talking about, and it is pretty trippy. And so people have taken this as one of the very first evidence that humans were interested in these psychedelic mushrooms. The point here is that people have been using psychedelics for various purposes for thousands and thousands of years. There's a long tradition, including with mushrooms. And I think that's something really important to keep in mind as we talk about these, bringing these into the Western medicine framework. Okay, so that's what I was saying before about how we start with psilocybin, and then it gets broken down to psilocin, which is the active metabolite. And I'm not going to get too much into the chemistry, but I just want to show you, this is what serotonin looks like. And even for non-chemists, you can see they look pretty similar. So it's not a surprise that psilocybin is acting at serotonergic receptors. Another thing to keep in mind is that while I was talking about the mushrooms, and actually the vast majority of people who have used psilocybin did it by eating mushrooms. Over 10% of Americans have tried the psychedelic. In the trials, we're using synthetic psilocybin. So this is pure psilocybin that was made in a lab. And so to keep it in mind that this is like the difference between caffeine and coffee. I mean, caffeine is the part that gets people excited about coffee, but there are other things too, right? It's a whole experience as opposed to just having a caffeine pill. Okay, I said I was going to get more into this potent effects on cognition, behavior, and thinking. So this is one way to try and capture the effects of psilocybin. What this graph shows is large number of healthy people were given increasing doses of psilocybin. You can see here the red, the green, and the brown, sort of increasing doses. And then they filled out a detailed questionnaire about their experience that asked all sorts of questions. And then it's graphed on this thing's called a spider plot. Basically, the farther away on each axis the dot is, the higher the people rated that domain. So if you look here, these blue, like audio visual synesthesia, that's, seeing sounds and hearing colors. That's what synesthesia means. And you can see that as people had higher doses of psilocybin, they rated that more and more strongly. Elementary visual alterations is, things like seeing squiggles or lines or dots. You can see that also is pretty common. Vivid imagery would be, a fully formed thing like a dragon or something like that. And changed meaning of percepts, that really means that the things that you see or perceive, what it means to you is different. So like you see your hand and you're like, oh, this isn't just my hand, but this is the hand of all humanity or something like that. And that's also a pretty common experience on psilocybin. People also have experiences of insightfulness, religious experience. This experience of unity is something that people talk a lot about. This is some people even describe it as a temporary dissolution of the self-other boundary, becoming one with the universe or nature, or your fellow man. Sometimes people talk about, and then of course a blissful state. I think that's pretty clear. And then we can compare it to ketamine, ketamine is an anesthetic that we also use as an antidepressant. And you can see ketamine doesn't have as much of the blue boxes. It has a lot more of the disembodiment. This is something that, as a dissociative anesthetic, it makes sense. This is people feeling detached from their body. But ketamine also has the experience of unity. Yeah, so this kind of gives you some sense of what the experience of being on a psilocybin is like. Another thing that people always ask me is, what about safety? We did this before. Everyone's going to take these drugs. Is it safe? Are they going to get addicted? And I like to show this graphic. So on the x-axis here, you can see the active dose divided by the lethal dose. So you want that number to be low because you want the dose that you use to get the effect that you want to be a lot smaller than the dose that will kill you. And then on the y-axis, what you can see is the dependence potential. What that means is how likely is someone to develop dependence and start basically escalating their dose and trying to get more and more of the drug and becoming more and more focused on getting the drug. And so addiction would be another way of talking about that. And so you can see in the top right corner, we have the sort of bad boys of pharmacology, right? Heroin is right up there where if you try it, it has you're very likely to develop dependence to it and want more and more of it and need more and more of it. And the active dose over the lethal dose is not as different as one would like. And so it makes it easier to overdose. And this is in the news, it's a huge thing. But you can notice there are a couple other players here. Nicotine, very likely for people to dependence potential. The overdose risk is lower, but it's not zero. And then alcohol, right? I think alcohol is one that we're all familiar with. And you can also see here that, the drugs that are illegal it's not related to exactly how dangerous they are, right? And, we have safe drug administration zones for alcohol in every town or almost every town across America with poorly trained, dispensers or bartenders, right? Whereas psychedelics are in the bottom left corner here. So people developing dependence for a psychedelic, sort of using it more and more, is vanishingly rare. It does occur, but it's very unusual. Mostly people use them in a self-limited way, like once every 3 months, once a year. And then the physiologically, they're very well tolerated. Even if you take a high dose, it won't kill you. That doesn't mean it's well tolerated psychologically, and we'll talk a little bit more about that. But this is just a starting place for the danger of using psychedelics. So another thing I want to get out in front of is about microdosing versus macrodosing. You may have heard about these different terms. They're in the public square or the zeitgeist at the moment. So microdosing, what that means is people are typically taking a sub-perceptual dose or a low dose. I say micro because it's not micro in sort of a standard units. It's not like as opposed to like a nano dose or a kilo dose. It's more of a slang, if you will. But people typically take a low dose, and when people do that, either they don't feel anything immediately, or they might feel something. So it's not totally subperceptual, but it's not psychedelic. It's not like all those experiences I was telling you about earlier. And when people do this microdosing, typically what they're doing is they're using it maybe every 3 days. There does seem to be some traditional cultures that have used low doses of psychedelics, but it's a lot less common than the macrodosing. The modern practice started with this book from 2011, as opposed to macrodosing. That's what's been studied mostly in the trials. That's where people take a high dose, where people trip or have a full psychedelic experience. And as I said earlier, when people do that, people are typically using that every month or more than every year. And that has a much stronger traditional history of use, probably for thousands of years. Let me talk about each of these separately. So for microdosing, there's a lot of talk about it helping people, but the evidence for that is pretty small. Basically what happens is a lot of studies have said, okay, hey, do you microdose? Oh, okay, well, tell us about your experience with it. And so it turns out that people who microdose say that it helps them. But of course, they know they're microdosing, and that's why they're doing it. So that doesn't tell us that much. Here you can just see that this is self-reported anxiety, depression, and stress. And you can see the people who microdose rate themselves as lower on those things. That's a start. It would be kind of concerning if it was the opposite, but it doesn't really prove it to us because the people believe in it and they know what the study's about. Surprisingly, there have been no randomized controlled trials of microdosing, but there was this one amazing citizen science study I just want to take a moment to talk about. So what this study did was take advantage of the fact that microdosing is so popular and that people who microdose are pretty dedicated to the mission of trying to understand if it works. So they recruited people online where they said, hey, are you about to start microdosing? If so, why don't you participate in our study? And so people said, oh, okay. And then what they did is they're using this very clever system of sending people envelopes and capsules that they could put their own drugs into. They were able to figure out a way to get people to blind themselves to their own drugs that they had at home. Let's think about that again. So people had some mushrooms at home, and they're like, I'm going to start microdosing with the mushrooms that I got on the black market. And this researcher sends you an envelope, and you take your mushrooms and you put them in the pills, and then you do this like sort of moving things around, and you don't know if you're taking a placebo, an inactive capsule, or you're taking the capsule that has your drugs in it. And they did this. They managed to complete it. They had almost 200 people do it. And there's a major advantage of this. One being cost. This is much cheaper than recruiting people and randomizing them, giving them drugs, and so on. And what you can see, they did three different groups. One was the placebo group. So if you're in the placebo group, you get inactive placebos the whole time. If you're in the half group, half the time you get placebo, and half the time you get active. And then the microdosing group, you have 2 weeks when you get active and 2 weeks when you get placebo. And what do they find? Well, this is a lot of lines. I'm sorry, it's a little bit busy, but basically what they found was that yes, some people reported better well-being, better mindfulness, better life satisfaction, but they didn't really get separation between the groups. So the microdosing group is in red, and you can see that it doesn't really separate. It's not different than the other groups. Maybe cognition is different, in that the microdosing group got better on cognition, but the other ones didn't. But actually, when they went back and they asked people, what drug did you think you were getting? It turned out that lots of people in the placebo group thought they were getting the active condition. And that explained the entirety of the effect. So if you controlled for how many people basically got it wrong, they thought they were getting the active drug, the differences between groups went away. So in this study, it really suggests a lot of the benefits of microdosing are placebo effects, people's expectations. But wait a minute, these people didn't have a clinical disorder. These were just random people from the internet who were going to use microdosing. We know very little about them. They don't have a clear disorder. So what are you even trying to improve? So this is the summary, my limited summary on what's going on with microdosing. We don't have clinical trial evidence. Positive expectations likely play a large role, but we haven't studied any clinical populations. In a healthy population, it's very difficult actually to show a benefit. And you think about that for a second, it's just because what are you trying to improve in healthy people? And healthy people are usually healthy, right? So they're usually pretty good at these different things that you're looking at. There's no clear deficit that you're trying to fix. And, the fact whether or not it works in healthy people doesn't really tell us if it's going to be an antidepressant, for example. So I think there's a lot of work still to be done with microdosing, and that will probably change in the next couple of years. Now going to macrodosing. So this is a tweet from 2021, actually, from a researcher from Hopkins. And this is, I like to show this because I think it really captures something about how modern psychedelic trials are done. I'll get into that in a moment, but basically they are a combination treatment. So with microdosing, you can think of it as like, oh, you just take this drug every 3 days, and it's a little bit like an SSRI or an antidepressant, and that you kind of feel better. Now, whether or not you really feel better more than you would if you were just taking sugar is still an open question. But with macrodosing, this higher dosing, it's not like that. The way it works is like this. So these are pictures from actually UCSF. So the patient will come in and meet with a psychotherapist for usually about 6 hours spread out over a couple sessions to do what's called preparation psychotherapy. And say it's a depression trial. They will, build trust and rapport, talking about their history of depression. There'll be a fair amount of psychoeducation where the therapist will tell the patient what they might experience when they take psilocybin. There's also practical things like here's the bathroom and here's the couch, and sort of, so nothing is surprising on the dosing day. Then the patient will come in on the dosing day, the psilocybin session. Their therapist will be there, and they take the drug, and then they spend the whole day in the lab, in this room, and they're encouraged to listen to music and have eye shades, and they lay down and go into their experience. But the therapist is there the whole day with them in case they want to talk about anything or they need reassurance. And you can see this is a blood pressure monitor, so we monitor blood pressure and to make sure everything's okay. Then as I said, it lasts about 6 hours. The person comes out of that. We clear them for them to go home. It's like when you go to the dentist and you have a big surgery or a colonoscopy. Someone has to come pick you up and go home. We don't let people just drive home afterwards. And then they go home, and then the next morning, and then a couple more sessions, about 6 hours again, they have what's called integration psychotherapy. And integration psychotherapy is where the patient will talk about what they experienced on the psychedelic and figure out how they want to integrate that into their lives and other changes that they might want to make. Currently, the approach that people use the psychedelic psychotherapy is what I described. So building rapport and trust is critical. It's a pretty non-directive, supportive approach. It's not like homework or a worksheet. There is this idea of sort of setting aside expectations and being open to unusual experiences, which the psychedelic experience is. And then another interesting element is music. So there's almost always, I would say always, there is music during the dosing session. And the patients and therapists all swear that it's incredibly important, which I think is pretty interesting. So now I have a video. So this is a video Um, not from us. This is a video
the
from
rest of my life.
a patient who participated in a study at Hopkins. He has prostate cancer, and he was had a shortened lifespan because of that. And he participated in a trial where he got psilocybin using that same model that I'm talking about. And he talks a little bit about what he experienced.
I would like to live my life fully. I'd like to be fully alive. I was greatly enjoying beautiful music, high quality, beautiful music playing in my ears, lying in the sofa, my two guides sitting there quietly, supportively. And what it led to was a reawakening, what it felt like when my first daughter, Tanya, died. And the feelings just came like I was completely into the strongest sense of despair and loss that I had after she died. And I howled. And I felt comforted that my guides they won't come and comfort me. They won't stop me. They'll let me go into it. And I did. And that's sort of almost 30 years of not denial, but putting it down, suppressing how that felt.
Just a couple of elements there that we often see. This is the memories that come back, these intense feelings, engaging with traumatic memories. We've heard this several times now where people say, it wasn't that I was in denial, but I just had pushed it down, and then somehow it comes up. The intense emotions that he's describing, and then the ability to somehow tolerate them.
And that was very liberating. After that, the experience with the drug, it became even more potent. Everything was animate. Like sitting here, all this around us, it's animate. Celebrating being part of this incredible living experience that we have. Humans are not separate from nature. And whatever happens to my bodily parts, they will go back into nature too. They'll be recycled. The result of those trips and the ability for me to experience more of myself and more of what life is, to become fully alive, as in ecstatic, very much enables me to go forward. I've been through periods where I'm not down on myself or feeling I'm not good enough, and much more tuned into the overall experience of what life is. Psilocybin, in the context of having support readily at hand, support that you trust, very important. So
just again, some elements there. We're talking about how he felt relief, he felt connected to the universe and nature afterwards, and felt that he could enjoy things again. These are all themes that we hear a lot in other studies as well. So I want to tell you about this is the first study we did at UCSF. That was, a couple of years ago now. If you look at the picture on the left there, that's the gay men's choir. And the people in white represent original members. People in black turned away from the camera represent people who died due to the AIDS epidemic. So you can just a snapshot of what AIDS did to a particular community in the Bay Area. And so we wanted to see if we could use psilocybin therapy to help people who had been through this. So people who were diagnosed with HIV before 1996, for them it was a death sentence because, at that point they knew what it was, and all their friends, or many of their friends, had already died from it. And it wasn't just any death sentence; it was also a stigmatized death sentence. It was gay men's disease or like that. So it was a really terrible time, of course. And yet, for some people who got diagnosed before 1996, they didn't die, either because they were genetic non-progressors. They had a genetic a genetic variant that made HIV go slower in them, or they survived long enough for the medications to come along. And the medications have really changed what HIV, the nature of the illness. So nowadays, it's much more like a chronic illness that people manage, and life expectancy actually isn't any shorter if you have HIV, if you take your medications. But for these people who went through this, many of them have a lot of complex sequelae, psychiatric sequelae from this. And as our first study at UCSF, we wanted to see if we could help them with psychedelics, both because the AIDS epidemic is near and dear to our heart at UCSF, but also because we saw this as a model of people surviving a horrible thing, like a natural disaster or environmental disaster or a war, where not everyone survives, but some people do, and they have to live with that. Or maybe even a global pandemic. That would be another example. And also, we thought this was a good place to start because just by the demographics, the people were older and they had other medical comorbidities, including HIV, and there were other medications. So we thought this was a place where we could leverage UCSF's expertise in medical care, sort of understand who we could treat with these drugs. The other thing that we did in the study that was novel was we used a group therapy format. So I told you about how other trials have done it, other studies have done it, where you have this one therapist, or typically it's even two therapists, and the patient. Well, we thought, why not have some of the preparation and the integration done as a group? If we're trying to help people not be alone, why make them go outside of the treatment? Because actually, it turns out in that Hopkins study that like I was in, we had heard that many of the patients really wanted to speak to other patients in the study, which I could tell you as a pharmacological researcher is very rare. No one in a Prozac trial is like, oh, I really want to speak to the other people who got Prozac. Also, psychedelics are often used in group settings in indigenous practice. And we were also concerned about the cost of the therapist. So group therapy has a long tradition of being used to try to be a more efficient way of delivering psychotherapy. So there are a bunch of reasons why we wanted to do it that way. So this is our study design. It was an open label study, so there was no control group. We did the preparation and the integration as a group. We had 18 people in 3 groups of 6. And demoralization was our primary outcome. Demoralization, you can think of it as similar to depression, but it's distinct. It comes from the palliative care world. It's really a loss of purpose and meaning in life. So that's what we were focusing on. And you can see here that, there were 4 group sessions for prep. Then we dosed individually. Everyone had a single psilocybin dose on different days because we didn't have enough space, so we couldn't dose them all at once. And then they got back together for more sessions as a group for integration. And then we followed people out to 3 months after the end of the psychotherapy. And what do we see? Well, this is demoralization, as I said, the primary outcome. You can see that it's high, and we give the psilocybin, and it goes way down, and it stays low for a long time. 3 months after the last psychotherapy session, which is almost 4 months after the dosing. This is consistent with other studies, open label, but still exciting. The other thing we were wondering about is, what about how challenging the experience was? So one thing we did is we had people fill out this challenging experience questionnaire, and the scores on this goes from 0 to 140, with 140 being the most challenging experience you can imagine. This questionnaire has questions like, I felt like I was going insane, or I felt like I was going to die, So, pretty scary things. And you can see that some of the people had very high scores on this. However, if you ask people how beneficial or harmful they thought it was, you can see that everyone thought it was very beneficial, or almost everyone, and nobody thought it was harmful. And how challenging their experience was not related to how beneficial or harmful they thought it was. I can also tell you that how challenging they thought it was also was not related to how much better they got. Everyone got better. Challenging experiences or not, that didn't relate to whether or not people got better. And this fits with a larger body of research that, what people think of as bad trips. In the setting where you have this therapist and you have all this support around the experience, bad trips can still be therapeutic. I think that's another reason why to have the therapist is so important. Okay, so now we said that there were a lot of clinical trials out there that were supporting the use of psilocybin. So here's one. This is a recent study that came out in New England Journal of Medicine. This was a large multi-center study. I wasn't involved in the study. And what you can see on the y-axis here, this is the change in your MADRS, which is a measure of depression. So the farther you go down on this, the more on average that group had improvements in their depression. And there are 3 groups here. So what they did is they took people with depression and they randomized them to get 1 milligram of psilocybin, which is a negligible amount. You won't feel 1 milligram. So they're using that as their placebo. 10 milligrams of psilocybin, which is a medium dose where you might feel something, or 25 milligrams of psilocybin, which is the full dose, which is the dose that the man in the video was talking about. That's the dose where people have a sort of dissolution of the self-other boundary. And in this study, they got the preparation and the integration like I described. And what you can see is that after the single dose of psilocybin, there was this large decrease in depression and much bigger in the 25 milligram dose versus the 1 milligram dose. So this is a reason that people are excited about psychedelics or psilocybin, is that you can get these rapid improvements in depression. The other thing that you can notice is that this improvement in depression lasts for many weeks. The difference actually in this study continued out to 9 weeks. Actually, I think it was 9 weeks, and was not really present at 12 weeks. But other studies have found separation, more improvement in depression in the active condition out to 3 months or 6 months even. And so that's why people are excited that you have this rapid improvement that's also durable after a single treatment. That's very exciting, if true. And you don't have to take the drug every day. You don't have to do it over and over again. You do it once, and people feel better for a long time. So I think that's where a lot of the excitement around these drugs are coming from. But the excitement is also a challenge because there's a lot of hype and hope. So the hope is totally understandable. As I told you, the treatments that we have are not that effective. There are a lot of people who are suffering, and everyone is desperate for new treatments. So people have a lot of hope that psychedelics are going to be that. On the other hand, there's a lot of stuff in the zeitgeist about how effective they can be. So here's a quote from Michael Pollan from his book, How to Change Your Mind, which really shifted the zeitgeist a couple of years ago, where he's talking about when he interviewed scientists. He said, "To solve the environmental crisis, to end war, bring peace, this is not what you expect to hear from scientists who are always very careful about their claims." So he said that there were scientists who were saying maybe these drugs could end war. Now, I'm not saying that they won't. It's just that's a pretty big thing. You can't do a clinical trial on that. The FDA will give you an approval for war ending. And then here's a quote from Rick Doblin, who's the CEO of MAPS, which is the nonprofit pharmaceutical company that's working on bringing MDMA therapy through FDA approval. And he said, I believe that fully globalized access to MDMA-assisted therapy can lead to a world of net zero trauma by 2070. And I'm not saying that that's not true. And I'm not even sure exactly what a net zero trauma means, but I think it means that we would be curing trauma as fast as we were creating it, so that there would be net zero. That's a pretty bold statement. Unfortunately, there's a lot of trauma in the world. These are the kind of that's how much hope there is for these compounds. I think one thing that's related to that is when people use these drugs. So this is from that Hopkins study. If you ask them, how personally meaningful was your psychedelic experience? Sorry, don't say psychedelic. Just say, what was the experience? People say, and in this study, they also used a low dose or a negligible dose. I think it was 1 milligram versus a high dose, which is 25. 62% of the people said that their high dose experience was among the top 5 most meaningful experiences of their entire life, which, is, I think, a really interesting finding. In like Prozac trials, we never even ask this because we assume it won't be. But personally meaningful, something about the psychedelic experience is very personally meaningful. So I think that adds to this, that the experiences really matter to people. And that's probably a good thing for a treatment, but it does make studying it hard. And so we did one thing to try and get at this. We had the opportunity to have the therapists in a trial complete our anonymous survey, where we asked them a whole bunch of questions. And one thing we asked them was about their own psychedelic use. It turns out most of them had used psychedelics, not so surprising. And almost all of them had used psilocybin in particular. And the median last use was in the last 6 to 12 months. I can tell you there was range, but some of the people had used a lot of psychedelics, like over 11 different kinds of psychedelic and over 50 lifetime uses. So there were some people who had a lot of experience with psychedelics, as in the people who were the therapists in the trial. Again, not a bad thing, just unusual for a pharmacological trial. We also asked people, the facilitators, compared to placebo, how effective do you believe psilocybin therapy will be for treating depression? And you can see that they all thought it was going to be more effective. And most of them thought it was going to be substantially more effective than placebo. Now, this is interesting. If you were to do, when people do psychotherapy trials, like with cognitive behavioral therapy, for example, most of the therapists probably would think that their cognitive behavioral therapy is going to be more effective. So it's very common for psychotherapists to believe in the psychotherapy they deliver. But for a pharmacology trial, I don't think it's as common. I mean, maybe the researcher is like, yes, I really think this, new SSRI is going to work. But all the people working on the study, I don't know what they would think. We don't usually ask this. But you can see here that this is, at least in this subset of facilitators, there were strong positive ideas about what the psychedelics could do. And why does this all matter? Well, what people think about how the treatment is going to affect them, what we call expectations, can have powerful effects on what happens to them. Sometimes we call these placebo effects. So this is just an example from the pain literature where this has been studied really well. What they did here is they gave people remifentanil, which is a very potent opioid. So it's like fentanyl. It's even more potent, I think. And they studied the effects of it on pain intensity. But the manipulation was they told people that this is going to work really well. They manipulated the expectancy. They're like, oh, this is a super effective analgesic. That's the positive expectancy. Or they said, oh, no, this isn't going to work that well. This is not a good analgesic. That's the negative expectancy. Or no expectancy. They didn't manipulate it. And baseline is where people started. And so what you can see is that if you give remifentanil with no expectancy, you see a decrease in pain intensity. That's good. That's what you expect. If you tell people it's going to be an effective analgesic, you double the effects. You see, this is much lower than that. So you're getting extra effect on the pain. And if you tell people that it isn't going to help them, so you're giving them remifentanil, you're saying this is not going to help your pain. you completely block the analgesic effects of the remifentanil. So what this study is doing is manipulating people's expectations about what will happen psychologically, just with talking. And this had very potent effects on the pain. So here we have this combination where we have people coming into the trials who really believe that the psychedelics are going to cure them. I've had people say to me, I know this is going to work for me, or this is the only thing that will work for me. And you have a situation where the facilitators and the other people running the study also really believe that. That's a good thing if you want big treatment outcomes, but it's a challenge if you're trying to show a drug-specific effect. And this brings us to the last thing. This is the only meme I've ever made, in that we often talk about masking or the double-blind studies. Now, what is a double-blind study? A double-blind study is where both the patient and the provider doesn't know which treatment the person got, right? Double, two of us. And why do we do that? Well, we do that because of the effects I was just telling you about expectation. You keep the patient unsure about which treatment they got so that their expectations can affect their outcomes. And you keep the researcher or the assessor or the therapist uncertain so that their expectations can affect the person. Because it turns out that it's easy to unconsciously communicate these things to people. For example, if you try to give someone a placebo, if you give someone a placebo injection, but you know that it's placebo, it's a lot less effective than if you give them a placebo injection and you don't know that it's a placebo. So we're communicating things in all sorts of ways. And so this meme is kind of pointing out that in many clinical trials, we talk about double blind, I put it in quotation marks, but we don't actually ask the participants what they thought they got. Because if you do, certainly, so this has been shown in antidepressant trials, often people do know what arm they're in, which is a big problem, And how do people tell? Well, a couple of reasons why. One is that they can tell about side effects. Another is that if they get better, they say that they got the active. Now that's kind of interesting because that suggests that, well, we don't want to control for that. But also there are the acute subjective effects. And so you could think with psychedelics, it's actually very difficult. No one's figured out a way to confuse people about whether or not they had a full psychedelic experience. It's kind of hard to imagine. So we've had quote unquote double blind trials. Like we didn't tell people like this is psilocybin, but in all the trials, people knew if they tripped or not. This is just, and that's an issue because we could have inflated effect size. So here's another study that was recently done by an excellent group in Switzerland. This is a similar patient group to the one I showed you before. This is major depressive disorder versus treatment-resistant depression. And again, it's the MADRS, which is this measure of depression. Now, instead of a change score, they just have the raw scores here. And you can see, and in this study, they use 15 milligrams, not the 25 milligrams that the other study did, so a lower dose. But everything else is pretty similar. Preparation, dosing, integration. Single dose. Right? And you can see that in this study, the people who got 15 milligrams of psilocybin have this big decrease that continues for at least 2 weeks. And if you look here, it looks like about 15 points, right? Yeah, so we have about a 15-point improvement with the 15 milligrams versus placebo. Now, this is an inert placebo. Now, you go to that study I showed you before, and you can see the difference between this and that is about, less than that. What is it? 9 minus, it's like 8. It was even less effective, even though this is more psilocybin. But overall, it's about a 15-point decrease from here to here. So look, from here to here, 15 points. From here to here, 15 points. So the same size improvement. But and then you have this 10 milligram dose, which has a smaller one in this study, but in 15, that's the one that had the big one. So the point I'm trying to make is in this 2-arm study here, where people know, oh, my options are either I'm going to get psilocybin or placebo, that probably contributed to the thing where if they felt anything psychedelic, they're like, oh, I'm in the active arm, and they got better. Whereas in this study, where people are like, oh, I could get 1, 10, or 25, and I know that 25 is the quote unquote right dose, the one that works, because there's been other studies for 25. Many people probably could guess that they were in the 25 arm, and they're the ones who got better. Now, this study, actually both studies, didn't actually ask people what they thought they got. So we don't really know. But I think this is a really important thing for the field. Just putting it all together, we have this hype and hope. It's really intense. People have these very strong positive expectancies about the treatment. We can't mask so people can really tell which arm of the study they're in. All of this contributes to inflated effect sizes. We have some ideas about how to solve this, but it's a very challenging thing. I'm going to talk about one other topic that we've been working on, which is kind of shifting gears. What about psilocybin and mania or psychosis? Is that a concern? And so this is a really complicated question because there are anecdotes. People have said, oh, people can become manic or psychotic after using a psychedelic, but it was so politicized and there's so much hype both ways, it's hard to get a straight answer. And actually, in all of the modern clinical trials with psilocybin, there haven't been any trials in people with bipolar. And actually, most of the trials have excluded people, not allowed people to be in the trial if they had a family history of bipolar, which is pretty unusual if you think about it. There aren't other places in medicine really where we say, oh, if you have a family history of this thing, you can't get this treatment. There's at least one in anesthesia with malignant hyperthermia, but I can't think of one in psychiatry. And the reason they did that is that people were concerned about this, even though the actual evidence for it was small. But, causing someone to have bipolar would be a really bad outcome. So people were being extra cautious. So we started by reviewing literature. It's always a good place to start. And we did a systematic review looking for any case studies that would describe this. And we found 4 cases of someone who did not have bipolar disorder, who took a psychedelic without other drugs and developed mania. And one of these cases is this one, 21-year-old woman, hospitalized 36 hours after using psilocybin. She had irritability, pressured speech, decreased need for sleep, paranoia, and delusion, which is a classic presentation of mania. She has a family history of bipolar. Someone in her family has bipolar. She was treated with drugs that we typically use for bipolar successfully. And then months later, she had what's called a mixed episode. It's another kind of manic episode that was unrelated to psychedelic use. So now what this case is describing is someone who was healthy, used a psychedelic, and now seems to have bipolar, which is very concerning. Now, would she have developed bipolar anyway? Impossible to know. And so this kind of highlights the challenge in the field. So the next thing we did was we said, oh, okay, well, there are a lot of people with bipolar around the world, and they probably have used psychedelics. Why don't we ask them? So we did this international survey. This is a map of where all the people who completed the survey were. Darker reds are more people in that country. So most of the people from North America, but you can see people were all over. And we asked them a whole bunch of things about what happens when they use psilocybin. We had over 500 people. Many of the people said that they have used psilocybin to try and treat their mental health. About a third of them said that they had worsening or new symptoms immediately or up to 14 days after using psilocybin, with manic symptoms and insomnia being the most common. So that's pretty concerning. 4% said they even needed to use the psilocybin led them to need emergency medical services, including psychiatric hospitalization. Also very, very concerning. On the other hand, everybody rated the harmfulness of psilocybin as low and the perceived helpfulness as high. Even the people who had worsening symptoms or who needed emergency medical services. Here, just the other thing we did is we had an open-ended question at the end. We said, "Oh, is there anything you want to tell us?" And usually, when you do that, people complain. But in our study, they told us about all these positive things. So here's just an example of one of the health benefits people describe. When I'm feeling the negative effects of my bipolar 2 disorder, I can sometimes put myself in the same headspace I was in when I took psilocybin, and it helps me calm down and put things in perspective. Okay, you can read it because I have to take a drink. I think this one here really smokes us. Some of the best growth in my life and also the worst experiences of my life really shows you this dual-edged nature of this. We then did follow-up in-depth interviews and basically found the same thing. People say, "Oh, it helps me, helps my depression, lifts my mood, but it makes me so I can't fall asleep." And this one person said, the only time I go into a full-blown manic episode is when I've done psychedelics. It unlocks it for me. So very concerning. So putting it together, I didn't say this, but bipolar depression is a big problem and we don't have good treatments. And so we need new treatments. Psilocybin therapy has significant potential. And for some people and some disorders, people can have transformative change and long-lasting benefits. But there are these challenges. So it's a combination treatment. So it's this psychotherapy and drug combination, which is new for the field. It's kind of a radically new approach that requires us to think about things in new ways. It also has challenges from like a systems point of view, like how would we even deliver it? And how are we going to do that effectively? And how can we regulate psychotherapy in a way where it's combined with the drug? Because we don't do that now. Psychotherapy is regulated one way and drugs are regulated another way. There's a lot of hype and hope, which is good in lots of ways, but also has challenges, especially because we haven't figured out how to effectively mask these trials, and we need new approaches. I didn't get into those last things, but the higher risk population is what I did. So, we are now doing a trial in bipolar depression, but it's really focused on safety because we know so little. But we think that the cost benefit for doing a trial it makes sense. But we'll have to see how it turns out. Okay, so this is just us. So I direct the Translational Psychedelic Research Program. We call ourselves Tripper. Cute name. That's our website. And then I can just tell you that we're doing a whole bunch of trials. I can't tell you about any of the data yet because they're not finished. But we're doing a trial of depression, anxiety in people with Parkinson's disease. We're doing bipolar 2 depression. We're doing a study in chronic low back pain. We're ramping up to do a study of methamphetamine use disorder, as well as anorexia in young adults, so 18 to 25-year-olds. We're also doing a study of psilocin versus psilocybin, as well as botanically sourced DMT and harmful alkaloids in a pill. And we are looking at several different possible mechanisms, but inflammation is one that we're particularly interested in. And here are all the people that make it possible.
The first question is, what is the effect on the heart?
I see that. So the effect is, so when we talk about macrodosing, so this is like you have to take one large dose. When you do it that way, people's blood pressure goes up temporarily and the heart rate goes up. So it's a sympathomimetic. So people, it's like your heart goes faster and you have an increase in blood pressure. Usually it's not an issue, but we make sure that people don't have high blood pressure beforehand. So people have to have their blood pressure under control. And then it's kind of like a hard workout a little bit. So it's very well tolerated. When people do it as microdosing, now this has not been studied as much because there haven't been studies of it. There is this concern about these heart valve issues. There was a drug called fenfluramine and I forget what the other fen was, but one of them had effects on a different serotonin receptor, the 2B receptor. And that's why fentanyl was actually taken away from the market, because some people developed these problems on their valves in their heart. So there is this theoretical concern that psilocybin and other psychedelics actually do have activity at the 5-HT2B receptor. And so if you were taking them all the time, like you do in microdosing, maybe that would cause valve problems. It hasn't been described. There aren't examples of it, but it's something that people are concerned about, and might be why there haven't been a lot of microdosing trials. But many people are doing this out in the world, and we would hear about it if there was a case, I think, but you never know. So those are the two.
How about, I'm trying to see what questions can be also grouped, but is it safe to use psilocybin if there's a family history of schizophrenia?
That's a great question. I would love to know the answer. I can tell you that every modern study, except for our bipolar study, has excluded people who have a first-degree relative with schizophrenia. Now, if you think about that for a second, a first-degree relative, that's a mother or father or sibling. But it's kind of weird, right? Because suppose you have one sibling or no siblings, or you have like 10 siblings, right? Like it's a very coarse thing, because, or if you're adopted, you don't know any of your siblings. So people are using that as sort of a hack or a rule of thumb for genetic risk, is what they're trying to do. And yet, we don't know exactly what the risk is in people like that. I can tell you that the risk of developing psychosis or mania after using psilocybin is probably very low in general, but it's not zero, because we can find these cases where it's happened. Mm-hmm. And we really don't know what that risk is, because it's really based on these anecdotal reports. But that doesn't mean it's not significant. I mean, it's a really bad outcome to develop schizophrenia. Mm-hmm. It's just a very difficult thing to study, because it's a low probability event. It's a complex thing that involves genetics and environment and what people are going through. And so, yeah, that's how I would answer your question. So I can't say yes or no. I would just say, beware, be cautious.
I think there's a couple of folks asking about psilocybin's research and looking at things like anxiety and rumination. Another attendee is asking about PTSD. Mm-hmm. So I'm also just curious if you have thoughts on resources, if people are interested, and there's good landing spots for people that want to kind of look at these different mental health diagnoses and what there is out there with psychedelic research.
So I don't know what the best resource would be. It's a good question. I think it's an evolving field. Most of the studies have been in end-of-life anxiety, so there have been a handful of really good studies in that space, and then depression, mostly just because depression is the most common, and the pharmaceutical companies are like, we're going to go for that, and let's go in. There have been, and then in those studies, people also measure anxiety, and those go down. There have been also some studies in substance use disorders, so alcohol and nicotine have been studied the most. And those also show promising effects. There's been a small study in OCD. There was a study in social anxiety in people with autism. I think that was also promising. So, I'm probably forgetting some at the moment, but there's studies that are happening, and there are more and more studies happening all the time. Anxiety by itself, so anxiety disorder, like generalized anxiety disorder, I don't think has been studied yet, though people talk about it. I suspect it would work. PTSD is something that we would really like to do. In our HIV study that I told you about, some of the people did have high PTSD symptoms, and those symptoms got better. But there actually hasn't been a trial on PTSD, which is a little surprising. I suspect it's because MDMA therapy has had a head start and was really only focused on PTSD. So they've kind of sort of captured a lot of the attention. But I suspect the psilocybin therapy will probably also be effective for PTSD. But it hasn't been studied yet.
So it's so interesting. I'm looking at this attendee's question, and I had a similar question. It seems the single dose of psilocybin can have a long-term positive effect. Why?
How is that possible? Yeah, right. All right. Well, that's the big question. Like why? Yeah, I said I showed you how it's done and all the things, but I kind of skipped over that. It's really, I would say because we don't know. We don't know why or how. I can tell you our working model. We know that in animal models, and if you study this in like a dish or an animal, that psychedelics induce neuroplasticity. Now, that's kind of a broad term. It can mean a lot of things, but practically, if you put psilocybin like in a dish with a neuron, the axons will sprout all these all these spines, like the outgrowths. Like it's very prolific, and you can show that it actually goes on to form new synapses in a full animal, a living animal. And depression in particular is associated with decreases in synapse formation and the sort of loss of synapses. So, decreased neuroplasticity. And so what people think, what the working model is that somehow taking a psychedelic induces this like plastic state. Clinically, people will talk about an afterglow. They feel different for like the week after one of these high dose experiences. And we think that that's why the psychotherapy is so important. I didn't really even talk about why it is, kind of hinted at it. We think that the psychotherapy is important for two reasons. One is safety. And I did talk about that using high doses, like the dose that we use clinically is a very high dose. Using that by yourself, sometimes people freak out or have challenging experiences that become bad trips because they can't manage it on their own. So I think that's really important. But we also think that the psychotherapy is somehow getting in there and having more effects on helping people change. And why do we think that? Well, one thing is that there's this paradox. I've talked about, psychedelics are so good, blah, blah, blah. But like millions and millions of people have used psychedelics. Well, as I said, over 10% of Americans have tried it. And the number's going up all the time. You go to raves or, Burning Man, and they're very popular. But not all those people, stop using drugs and have their depression and anxiety cured. And there is even some evidence. Now, this is, again, subject to, so self-report, anecdotal thing, that when people are using it at a rave, they feel good for a while, like days, and they feel like, oh, everything's possible, but it kind of fades. It doesn't last in this way. So I think if you push most psychedelic researchers, that there's something that's going on there about this combination of the environment and the drug. Now, I could be wrong about that. There are animals. The counter argument would be that animals seem to have long-lasting antidepressant effects after psychedelics. You give a single dose of a psychedelic in certain animal models, you can get these long-lasting effects that look like antidepressant effects. Now, the mouse or the rat can't tell you that they're not sad, or so the models are, how I put it, they're just models of depression. But still, you can find effects on the behavioral outputs in the rat like a month later after a treatment. And a month for a rat is like a lifetime. So, and nobody's shaping the experience that the rat goes through. No one's doing the prep and integration. So I could be wrong about that. Maybe it's only for safety, and maybe actually, but I still think all these people are using psychedelics out in the world, and they're not all cured. It's an unclear place. But on the other hand, we know that you can have long-term effects after using a drug. Ketamine, we use ketamine as an antidepressant now, and it's cleared from the body within hours, but the effects last for at least days or a week in depression. That's pretty compellingly shown. So it's not impossible that it can last a long time. It's just surprising. What I can tell you clinically, or sort of the patients say, is they will say, oh, I had a realization that I don't need to do that thing anymore. I mean, I mean, I laugh because it's like, right, yeah. Like I met a guy, I was giving one of these talks to the NIH and it was open to the public, and someone came and they're like, oh, I was a participant in the alcohol study. And we were debating about the subjective experience. I said, oh, what about, was your subjective experience important? And he said, well, I saw an alcohol bottle in the desert and the alcohol bottle dissolved. And I knew I would never drink alcohol again. And you're like, okay. You're like, yeah. And he's like, it was incredibly powerful. And you're like, okay. But I don't know what to make of that. I mean, it's good. Or patients, I've heard people say things like, I realized I really I had to stop smoking.
Mm-hmm.
Which, right? It's like it just has a weightiness to it.
Yeah.
Even, or patients will say things like, I was able to forgive myself for this thing or that person or something, things that people knew they had to do but couldn't, and then they could. I mean, that's a little hand wavy, I know, but that's what seems to happen.
I'm curious, as you're talking about the lasting effects in animals and the examples of the mice and the rats, if they're much better at having beginner's minds than us humans.
It's true. They don't. Yeah, well, I think that's a really good idea. I hadn't thought about it like that. That's right. I mean, they don't.
Come with a lot more baggage.
Yeah, right. They're like, oh, what's happening now? What's happening now? They don't.
What's next?
Right. What's next? And maybe that's interesting. That's a really interesting idea. I've never heard anyone put it that way. Because like they start fresh and maybe it resets them.
Yes, every day is a new day. It's interesting. I feel like some of the critiques I've heard of kind of the synthetic use of psychedelics and then this kind of quote clinical setting versus people doing it indigenously or in community with natural substances. I don't even really know what my question is, but just if you can kind of speak to, those are really different experiences.
Yeah.
And, I'm curious. I know obviously we need controlled environments to collect data, like that's important, but it really kind of potentially strips away a lot of the meaning that people maybe are looking for or coming to in the experience. So I'm curious what you think. I think part of my question is like, once we have data and we know these are good doses and this is what it's helpful for, like, is it going to move back out of the clinical setting so that it is more of like a nice, that setting is really attended to for
right. Well, so a couple of things. First thing I would say is in the clinical setting, the setting is really attended to. So the therapists and the dosing room, a lot of attention is put to that. And actually we don't do what indigenous groups do with setting, but we do our own thing. We do our Western medicine thing. Like they need a doctor, and there's like the hospital building, and we're measuring their symptoms. And we have a lot of our rituals, if you will.
Ceremony and ritual.
Yes. Taking their blood pressure. Like this is a ritual. I mean, we need to know those numbers, but still, we're also doing this thing. So the people actually in our studies find it very meaningful. And other people's studies too. So it's not that like it's cold or indifferent or anything like that. But it's different and it's very costly for one thing. And it's very specific, and you have to get into the trial. And it's a medical model. It's something that insurance might theoretically pay for, or the VA where I work. But these drugs or these compounds, they have indigenous use, and they're part of religious and cultural practices. And that's a whole separate thing. And then American society is also grappling with what we think about drug use in adults in general. And like I showed you that thing about, which drugs are the bad ones and the good ones, and why are certain ones illegal and other ones are not. A lot of it actually has to do with racism, I think, which ones were targeted. And like we tried to make alcohol illegal, and that didn't work out that well just because people refused. White people, basically, right? And so I'm not a politician, and I don't know, but society is trying to decide, like, well, aren't we going to allow people to use psychedelics? And if we do that, how is that going to look? And like, what does that mean? in practice, in California at least, psilocybin is basically decriminalized. Like, I don't think people are going to jail for using psilocybin. Again, I'm not a politician, but you can go to Oakland. There are stores. You can buy these things. And the vast majority of people use these drugs like with their friends or on their own and at parties, not as therapeutics, that, for fun. And I have my personal views on all of that, but what we're trying to do in the lab is to see, what happens when we do it in this highly controlled way for sick people? Can we do it safely? That's a really important part for people who are, have a serious problem like severe depression. We did a study in people with Parkinson's. So, they have neurodegeneration damage in their brain. They have a risk for psychosis as well. Like, will they become psychotic? People with bipolar, what will happen if we give a high dose? These are open questions. And then we're hoping that if it really is effective and safe, then it'll be a treatment that would be in our armamentarium. And as I said, insurance would pay for it, which I think is the way we can help the most people. Mm-hmm. But I really don't, and I think most psychedelic researchers will say, this is a whole parallel path from ayahuasca ceremonies in the Amazon, or ceremonial use of mushrooms, or all the different religious practices. Like, those should continue, and that's not, we owe a debt to them. Mm-hmm. Obviously, the technology, the knowledge about using these drugs, we owe a debt, and we don't want to interfere with it. It's like a separate thing. That's how I feel about it. But it's a complex issue. Colonization, sort of stealing things, different ideas like patents and indigenous property. So, it's a big thing. But the one thing I want to be really clear is we don't want to do cultural appropriation. So, like, our dosing room has pictures of California nature. That's what we do. And we're not like having Buddhas or religious things.
Great. I really appreciate that answer and your thoughtfulness. Thank you. There's a few other questions in the chat. I also wanted to ask quickly, this might be a large question, but I work with a lot of adolescents and young adults and parents saying, what about this for an adolescent? What about this for my kiddo who's gone through 3 or 4 antidepressants and they're still not getting better? And my response is, I don't have an answer for you. There's no data, but I'm just curious what you think about the adolescent and pediatric brain and this medicine.
So this is something I've thought a lot about. My collaborator, Dr. Raymond Flesch, is she's a pediatrician and an adolescent medicine doc, and we're working together on an anorexia trial. And I've learned a lot from her. And anorexia is one of the top 2 most lethal psychiatric disorders. 10% of people will die. And 90% of the people who have it are younger than 18. And if you don't get treatment in the first couple of years, your chances of recovery go way down. So we've been talking about it, about whether or not we should, study it, not whether, when that makes sense. Mm-hmm. So that's one thing. So, like, anorexia is a place where I think is really important because it's such a severe illness and it's affecting people so young. People have, of course, been reluctant to do this. Nobody wants to hurt a child. And this is a double-edged sword as well, because, pediatric populations, get medications way after adults have gotten them, like as a field. Mm-hmm. But that also means that they don't get exposed to the risks as soon. It's a challenging thing. As you know, the brain's still developing, and it's still developing through 25 or even beyond. And so many of the modern studies have actually only taken people 25 or older, 26 or older. That's for a couple of reasons. One is this development thing. The other thing is people didn't want to have anyone develop bipolar in their trial. And that's when the time of risk. Mm-hmm. So I agree with you. Like, we know so little about this, and these drugs we do know can be very potent and inducing plasticity. How that interacts with the developing brain is really a totally open question. Now, of course, there are adolescents out there using psychedelics, and many of them do fine, but that isn't that reassuring. I guess it's a little bit reassuring, but it's not that reassuring. I think that what's probably going to happen is when the clinical need is really high. So it's all the thing in medicine. You know this, but we're always doing cost benefit. There's no treatment that doesn't have a risk. Even the ones we think of as very safe, sometimes people have, bad outcome. And we basically are balancing cost and benefit all the time. And in research, it's the same, where we're like, well, we don't know exactly what the risk is here, but, what's the possible benefit? And, how can we mitigate these risks and take a stepwise approach? So I suspect that what's going to happen is we're going to do more research on psychedelics. We're going to have more knowledge about how to do this. We're going to study it in young adults and hopefully show that that's safe. And then something like anorexia, where the need is very high and people are dying, someone will do that study, and that's how it will start. Of course, everyone's worried that all the teenagers are going to go out and use it. I don't know. That's a bigger question than me. But do I think that there are particular conditions where the cost benefit is worth it? I think so, at least to study it. Severe, just like you say, severe depression in adolescents. I mean, that's a common thing. Mm-hmm. Severe drug use disorder. That's another common thing that can happen in teenagers. If you could really, if it's true that psychedelic can be used to fix that, let's just imagine that for a second, then you could totally imagine it being worth it, because those things are really bad for developing brains already, right? So, yeah, that's my answer to that. Yeah, I see a quick question here about SSRIs. Yeah. So I didn't have time to get into this. It's a big question. All the trials have excluded people on SSRIs. They're like, oh, you're depressed? You can't be on SSRI to be on our trial, which actually is a huge problem. It's actually really surprising. And one way, on the other way, it's not so surprising because people are worried about the SSRI and it's all serotonergic and they think it's going to interact. People have been concerned about serotonin syndrome, which is what happens when you have too much serotonin, but I think the risk of that is very low, because actually it's never been described with psilocybin by itself, or hardly ever. It's like a vanishingly rare. But the trials have not been done. We did a study with Reddit, amateur psychopharmacologists, and I can tell you that on Reddit, a lot of people talk about how when they're on an SSRI, it blunts the effects of the psychedelic. They just don't have as intense a trip, or they have no trip at all. That is the lore, but it hasn't been shown in the study. No, at the trial, no. So, that's what I can say to that.
Dr. Woolley has shared, if you're interested in any, finding out more about the research that his team's working on, you can visit his website. So thank you, Dr. Woolley. Thank you for everyone for joining us.